Okay, so this is chapter 33, nursing care of patients with upper gastrointestinal disorders. For ATI, this is chapters 42 through 44. The chapter starts on page 716 in your text. In this chapter, we're going to talk about disorders of the upper gastrointestinal tract. We'll also discuss some eating disorders and obesity. And then also diagnostic testing and nursing care for patients that have disorders of the upper GI system. It's very, very common. Most people, if not all people, will experience nausea and or vomiting at some point in their life. Nausea is just the urge to vomit or the feeling like you have to vomit, where vomiting is actually the expelling of the stomach content through the esophagus and the mouth. Vomiting is really a protective function to rid the body of harmful substances. This reflex is controlled by the vomiting center in the brain. Many different things can cause nausea and vomiting. Stress, change in hormones with pregnancy, different medications, certainly motion sickness or, riding in cars or other types of motion can cause nausea and vomiting. And then, as discussed before during our otic lecture, certainly vestibular reactions can cause nausea and vomiting as well. Nausea and vomiting can be very self-limiting, so it is possible that no intervention may be needed. Certainly we need to think about airway protection. This is a top priority to prevent aspiration. There are many medications that can be used to control nausea and vomiting. Some examples of this would be Zofran or Benadryl, Reglan, Phenergan, and Compazine. That's just a few. If patients have prolonged vomiting or have been vomiting a lot, they may need to be given IV fluids for replacement. NG tubes can be used to decompress the stomach. Patients, when they have had problems with nausea and vomiting, are first started out back on a clear liquid diet once you can get that nausea and vomiting under control. And then they're advanced as tolerated. Usually they go clear liquids to full liquids, and then what is known like as a brat diet or a very bland, so bananas, rice, applesauce, and toast. And then if that's tolerated, they can go back on a regular diet. Some of the nursing diagnosis would be nausea related to various causes that we already have talked about. Certainly the risk for aspiration related to a decreased gag reflex or unconsciousness, or just purely from vomiting. Sometimes aspiration can happen depending on positioning and what's going on. And then deficient fluid volume related to the vomiting. As discussed before, anorexia is really simply just a lack of appetite. It can be caused by various different conditions, medications, emotional stress, and certainly some other psychological conditions. Not eating for a prolonged period of time can certainly cause some serious problems like electrolyte imbalances, which then can lead to cardiac dysrhythmias. Nursing is concerned with measures to help with nutrition, and so we're going to document I's and O's, certainly monitor vital signs and electrolytes. They may get an EKG depending on their situation. And we need to come up with strategies to aid with weight gain, certainly offering foods that they like, making sure there's no noxious stimuli, etc. can be really helpful. So then they're an eating disorder. Then they're an eating disorder, anorexia nervosa. I'm sure that most of you, or if not all of you, have heard about this. This eating disorder is thought to be more of a psychological in origin. It most commonly occurs in girls that are between the ages of 12 and 18, usually from middle or upper class Western culture. Girls generally tend to have a low self-esteem and seem to be, or girls with a low self-esteem tend to be at the highest risk for having this eating disorder. They may have a phobia of weight gain or be afraid of loss of control or be mistrusting. The treatment goal is to restore nutritional health. It's a very serious condition. About 18% of the women that get this will die as a result of starvation and its complications. Signs and symptoms include severe weight loss, low self-esteem, compulsive types of dieting, and disturbed body image. Later on, as the disease starts to progress, patients might experience amenorrhea, electrolyte imbalances, which again can cause cardiac dysrhythmias, constipation, dry skin, bradycardia, hypothermia, hypotension, muscle wasting, and facial puffiness. They may also get like this downy kind of hair that's covering the body. This is called lanugo. Some of the complications occur because of the chronic poor nutrition from the body trying to conserve energy in a state of starvation. Complications include poor nutrition, again, electrolyte imbalances, those decreases in vital signs, osteoporosis, muscle loss, and also diabetes. Treating this disorder is really very complex and may require a multidisciplinary approach. Some of the strategies are to use praise and rewards for small achievements in weight gain, not necessarily around food intake. Certainly, the patient's self-image and self-esteem that are the underlying cause of the disease have got to be addressed in conjunction with the nutritional aspects in order to make treatment successful. We're also going to monitor vital signs and daily weights, intake and output of food and fluids, and then certainly it's creating that therapeutic type of relationship with the patient is going to be important, so that hopefully there's that trust so that they are more likely to listen and work on the plan with you. Another disorder is bulimia nervosa. Patients with bulimia nervosa eat compulsively, and they eat like huge amounts of food, and then they self-induce vomiting. This is known as binging and purging. This disorder, like anorexia, is commonly seen in young women. Some of the things that you'll see are enamel erosion of the teeth, calluses or scars on the knuckles or the backs of the hands from inducing vomiting. It can also lead to metabolic acidosis from the loss of the gastric acid in the stomach. The treatment of bulimia is basically the same as anorexia, with the goal being to restore nutritional health. Nursing care, again, a therapeutic relationship is really important. So being understanding and non-judgmental can really, really help. Again, we're going to be monitoring vital signs and daily weights, and also intake and output of food and fluids. So nursing diagnoses for eating disorders. Imbalanced nutrition, less than body requirements related to either the inadequate food intake or the self-induced vomiting, and or chronic or excessive laxative use, because folks with eating disorders tend to use those as well. Body image disturbances related to psychosocial or cognitive or perceptual changes. A lot of those folks that have anorexia do not see themselves as thin at all, even though they can be completely cachectic and have no, just be skin and bones, literally skin and bones. I'm going to switch gears and talk about obesity. Using a height-weight chart, weight that is 10 to 20% above the ideal body weight is considered overweight, and then if it's greater than 20% above ideal body weight, then the person would be considered obese. Body mass indexes, or BMIs, are a pretty common way to look at ideal weight, or ideal body mass, I guess you would say. And this calculation uses like a height to weight ratio. You can see there's a table in your book. It's in the bottom left-hand corner. It's on page 720. Normal BMI is 20 to 25. 25 to 30 is considered overweight, and then if the BMI is greater than 30, the person would be considered obese. A small percentage of obesity is attributed to metabolic and endocrine types of abnormalities, but for the most part it's due to a caloric intake that exceeds energy expenditures, so too much in, not enough out, basically. Comorbidities include atherosclerosis, heart disease, diabetes, hypertension, sleep apnea, osteoarthritis, certainly decreased mobility that can lead to a lot of different issues, depression and low self-esteem as well. A BMI greater than 40 is considered to be morbidly obese, and they may experience severe sleep apnea or heart failure, which can be life-threatening. The therapeutic interventions include weight loss through exercise and calorie restriction. So the patient should be educated on healthy and well-balanced diet, but the bottom line really is eat less and move more. There are a ton of support groups out there and programs out there that help. Some examples are Weight Watchers or TOPS, which is Take Off Pounds Sensibly, and they're just support groups that people can join to help with weight loss. Behavior modification may also need to be included in the weight loss plan. And then patients may also use medications to suppress appetite or fat absorption, but this should only be done for a short period of time. Patients who are morbidly obese who do not respond to medical methods of weight loss may be candidates for weight loss surgery if they meet an established criteria. The types of weight loss surgeries include restrictive, which limits how much is in, or how much the stomach can hold, or malabsorption, which decreases calorie or nutrient absorption. Or there can be a combination of surgeries, or combination surgeries that not only limit how much the stomach can hold, but also decrease absorption as well. Again, restrictive surgeries limit the size of the stomach. Examples of these surgeries are gastric banding and vertical banding, gastroplasty. By making the stomach smaller, this limits intake and reduces appetite, and also slows digestion. The band is adjustable, allowing for different sized pouches. With this type of surgery, malabsorption issues are usually or are avoided. The vertical banding gastroplasty creates a pouch that also limits food intake using like a staple line and a band. The Roux-en-Y is a combination surgery which creates a small pouch using a staple line and then a section of the small intestine. There's a figure in your book, it's on page 723, that shows different pictures of these types of procedures a little bit better. The most common side effect from any type of bariatric surgery is vomiting. This is usually from overeating or not chewing food well enough. There can also be erosion of gastric tissue around the bands or at the staple line, which then allows leaking of stomach secretions into the abdominal cavity. And this, of course, can lead to peritonitis, which can be a very serious complication. It can also lead to infection and death with any of these complications. So pretty serious complications that can happen around gastric surgeries. We'll have an NG tube after surgery. We need to make sure to keep the head of the bed elevated to ensure good lung expansion. Patients are started on a clear liquid diet, then advance to full liquids, pureed foods, and then about 6 weeks after surgery, they're able to eat regular foods again. Again, patients need to be taught about limiting or restricting the amount of food at one time, as the pouches are very small and overeating can lead to complications. They will also need to increase protein intake. So nursing diagnosis would be imbalanced nutrition more than body requirements, and this is related to caloric intake that is greater than what the body needs, or it can also be related to decreased activity levels. The expected outcome would be for the patient to achieve and maintain weight loss to a specified weight. This here to oral health. This is very important to overall health. Respiratory illnesses and cardiac disease are associated with pathogens in the mouth. The current recommendations include brushing the teeth twice a day, flossing at least once a day, and then using mouthwash as well. Regular dental care is also very important in prevention of infections. It's been found that the use of a chlorhexidine gluconate mouthwash in long-term care setting reduces pneumonia and also reduces ventilator-associated pneumonia in the acute care setting. So really important to give all of our folks good oral hygiene or instruct them about good oral hygiene. Artificial joints or some heart conditions may need to get prophylactic antibiotics prior to dental procedures to prevent the bacteria from bacteria entry into the bacteria entry into the tissues and creating bacterial endocarditis. There are many causes or many times when they may need prophylaxis. Another issue with oral health care is dry mouth. And there are many causes for dry mouth. It is important to know that this can lead to really rampant tooth decay, putting all of the teeth at risk or dentisha at risk. Water is a common substitute that's used. You know, when people feel like their mouth is dry, they may drink a lot of water. But this doesn't really contain the necessary compounds such as lubricants to protect the teeth. So really some type of artificial saliva substitute should be considered. So folks who have dentures still need to be screened for proper fit. Sore areas, oral cancer detection, any types of oral fungal or bacterial infections. And we still need to stress that oral hygiene is very, very important. And then lastly for this slide, gingival recession or the gums receding. This happens as people age, which is not uncommon. Fluoride gel or rinse is recommended to protect the teeth from decay. Gingivitis, this is an inflammation of the gums, and it can lead to bone loss, which then results in periodontitis, which then can lead to tooth loss. So flossing daily is very important in preventing gingivitis. So we want to stress that with our patients. Candida albicans, this is a yeast infection. Nystatin is, excuse me, a common medication that is used to prevent it. These yeast infections can be caused by certain medications or systemic conditions or chemotherapy as well. And then angular chiliosis is a red, raw corners of the mouth. And this can be caused by an infection or vitamin deficiencies. Treatment really depends on what the cause is. So it'll just really depend. Okay, sorry about that brief interruption. So moving on, stomatitis. Stomatitis is just a general term for any type of inflammation in the oral cavity. There are many causes of stomatitis, but the most common are canker sores and herpes type 1. For anywhere in the oral cavity or the throat, people who drink alcohol or use tobacco in any form are at an increased risk. If detected early, it is curable. Signs and symptoms include ulcers that may be painless at first but become painful as the cancer progresses. Difficulty with chewing, swallowing, or speaking may also be present. They also may have some swollen lymph nodes on the diagnosis, but may include radiation, chemotherapy, surgery, or a combination of those treatments. Radical or modified neck dissection is a common surgery for people with oral cancer, and we're going to discuss that here next. Extent of the surgery on the extent of the cancer. The tumor, along with the lymph nodes, muscle, blood vessels, glands, and part of the thyroid are usually dissected out. Usually a tracheostomy is done in conjunction with this surgery in order to protect the airway. Preoperative teaching will include information about the procedure and how the patient will be able to communicate after the tracheostomy is placed. Postoperatively, the concerns really, the huge concern is going to be airway, but also communication and nutrition. Patients may require a feeding tube because of swallowing issues that could happen after the surgery. As with oral cancer, esophageal cancer is, or people that smoke or drink are at a higher risk for esophageal cancer. This type of cancer is usually detected late because of the proximity to the lymph nodes. It metastasizes. Signs and symptoms that occur in the late stages include difficulty swallowing, feeling full, chest pain or foul breath, or food regurgitation. Diagnosis of esophageal cancer is done by EGD, or esophageal gastroduodenoscopy, and then a biopsy. The endoscopic examination of the mediastinum is also done to see if the cancer has metastasized to the lymph nodes or other surrounding structures as well. Again, like other types of cancer, it can be treated with radiation, chemotherapy, surgery, or a combination of these interventions. Surgeries include esophagogastrostomy, which is a resection of the esophagus with anastomosis, or a connection of the remaining part of the stomach. Another surgery that can be done is a Dacron esophageal replacement, which is a prosthetic esophagus, or they also can use a section of the colon to replace the esophagus, which is called an esophagoenterostomy. Nursing diagnosis includes pain related to tumor and pressure exerted on the surrounding tissue, risk for deficient fluid volume related to decreased intake or imbalanced nutrition, less than what the body requires, and also related to decreased intake. Hiatal hernias. This is where the lower esophagus or stomach slides up through the hiatus of the diaphragm into the thorax. A sliding hernia is the most common. This is where the stomach, again, slides up into the thoracic cavity when the patient is laying down, and when it goes back into, and then it will go back into the abdominal cavity when the patient is upright. Hiatal hernias occur most often in women, in those over 60, and obese or pregnant people. If the hernia is small, it may not produce any discomfort, but if it is large, it can cause pain, heartburn, or the feeling of fullness and reflux. Diagnosis can be done with x-rays, and fluoroscopy is also used to diagnose hiatal hernias. Non-therapeutic interventions for hiatal hernias include the use of antacids, instructing the patients to eat small meals, no reclining 1 hour after eating. We can instruct them also to raise the head of their bed to 6 to 12 inches. No bedtime snacks, spicy foods, avoiding alcohol, caffeine, and of course talking to them about smoking cessation can also help. Surgical interventions for hiatal hernia is called a fundoplication, and this is where the stomach fundus is wrapped around the lower part of the esophagus. For nursing care for non-surgical interventions, teaching should include strategies for reducing pain. If the patient is having surgery, they should be given information regarding the procedure preoperatively and assessed for dysphagia during the first meal after surgery, as if dysphagia is present, it could indicate that the repair may be too tight, causing obstruction, and if this happens, the doctor should be notified immediately. Gastroesophageal reflux disease, or Gerd, is where gastric secretions reflux back into the esophagus because gastric secretions are very acidic and contain digestive enzymes. The esophagus is damaged. Gerd is caused by the lower esophageal sphincter, or LES, not closing tight enough. Gerd is common in folks with hiatal hernias, and is also fairly often occurs in older people. Signs and symptoms include heart regurgitation, dysphagia, and bleeding. Aspiration is a huge concern. Scar tissue develops as a result of the inflammation. Some of the diagnostic testing includes barium swallows, esophagoscopy, looking down into the esophagus with a scope, and then also pH monitoring. Some therapeutic interventions, first lifestyle changes like weight loss or low-fat diets, higher protein diets, eating smaller meals, drinking fluids between meals instead of with meals. This can help with that overfilling of the stomach as well. Avoiding late evening meals. Medications may include antacids like Tums or Mylanta, or H2 receptor antagonists like Tagamet or Pepcid, proton pump inhibitors, Nexium or Prevacid, or the prokinetic agents like Reglan, which increase gastric emptying and function also to help with the lower esophageal sphincter. Fundoplication can be done to alleviate symptoms if the problem is a hiatal hernia. Other procedures include Esophagex, which uses an endoscope to tighten the lower esophageal sphincter. Other endoscopic procedures, such as a strata, can be done, which uses like radio frequency waves that are injected into the muscle of the LES to form collagen contractions, which creates a barrier against the reflux. Complications of Gerd include esophagitis, a Barrett's esophagus, which is precancerous, esophageal cancer, bronchospasms, laryngospasms, and then aspiration pneumonia as well. Ablation is a technique in which the tissue is exposed to heat energy and is destroyed. The nursing diagnosis would be acute pain related to inflammation of the esophageal tissue. For nursing care, this would include education on lifestyle changes discussed earlier. We may also teach to avoid caffeine or milk products and spicy foods as well. So for Mallory-Weiss tear, this is a longitudinal tear in the mucosal membrane of the esophagus at the stomach junction. Tears from sudden or powerful or prolonged force. This can be because of coughing or vomiting, seizures, or we can actually create these when we do CPR as well. In most patients, a hiatal hernia is present with Mallory-Weiss tears. About 15% of GI bleeds are caused by Mallory-Weiss tears, or the upper GI bleeds are caused by Mallory-Weiss tears. Signs and symptoms include bright red blood, bloody emesis, or bloody or tarry stools. Diagnosis of Mallory-Weiss tears are done with EGD. Again, we should be monitoring H&H for sure to determine the amount of bleeding that is happening, and certainly monitor our patients for problems with bleeding. So usually no intervention is needed and the tear heals in several days. Medications such as proton pump inhibitors or antiemetics might be given. They can also be treated with injections of epinephrine to constrict the blood vessels, or endoclips can also be placed to stop bleeding. If excessive bleeding occurs, then certainly the patient may require a blood transfusion as well. Up to about 75% of those with Mallory-Weiss tears are people who use alcohol excessively. So if the person is an alcoholic or uses alcohol excessively, then they are at a high risk for these Mallory-Weiss tears. Nursing care includes monitoring patient for bleeding. You would also want to teach the patient about signs and symptoms of bleeding. We also need to teach patients about medications and to avoid alcohol or get treatment for alcohol problems if they are in that group of people that drink heavily. So esophageal varices, this is a condition that develops from portal hypertension, which is often due to cirrhosis of the liver. Rupture of the varices can cause a life-threatening problem. This particular problem actually will be covered in a little more depth in Chapter 35, so we're not going to go into it in totality here. Gastritis, this is an inflammation of the stomach that can be acute or chronic. Causes include diet problems, microorganisms, medications, stress or trauma. Other factors include smoking, radiation, NG suctioning, and reflux of bile. Signs and symptoms include abdominal pain, nausea, and anorexia. Treatment is really to remove the irritating substance. They'll be given a bland diet of liquids and soft foods, and antacids may be helpful as well. As mentioned, the inflammation can be acute or it can be chronic and occur over time. Chronic gastritis is classified as type A or type B. So this happens when gastritis happens when the protective mucosal barrier is broken down, and then autodigestion by the hydrochloric acid and pepsin occurs. With severe gastritis, mucosa can become gangrenous and perforate, which can then lead again to peritonitis. Scarring can also occur, which can cause pyloric obstructions as well. Signs and symptoms of gastritis include abdominal pain, nausea, vomiting, anorexia, abdominal tenderness, that feeling of fullness, reflux, and belching as well. Treatment includes removing any of the irritating substances, and a bland liquid or soft diet may be given along with antacids, as mentioned before. Medications can be given to control vomiting and pain as well. Now to turn back to those chronic gastritis, and we'll discuss type A and type B as well. So type A chronic gastritis occurs in the fundus of the stomach. It is referred to as autoimmune gastritis, and it is often asymptomatic. Because these patients do not secrete enough intrinsic factor, they have difficulty absorbing B12, which leads to pernicious anemia. Type 2 chronic gastritis affects the lower end of the stomach near the duodenum and associated with H. pylori. Signs and symptoms include poor appetite, heartburn, nausea and vomiting, belching, and a sour taste in the mouth. If it's caused by H. pylori infection, the problem will be treated with antibiotics. Peptic ulcer disease is an erosion of the GI lining. The primary cause for this disorder is H. pylori. Other factors that might contribute to peptic ulcer disease are smoking or chewing tobacco, stress, excessive or I would say beyond moderate caffeine use, medications such as steroids, aspirin, or NSAIDs. Ulcers are named by their location, so esophageal, gastric, or duodenal. Symptoms vary with the location of the ulcer. Signs and symptoms of gastric ulcers include a high left epigastric or upper abdominal burning or gnawing type of pain. This is increased 1 to 2 hours after meals or with food. For duodenal ulcers, signs and symptoms include this mid-epigastric or upper abdominal burning or cramping type of pain. It is increased 2 to 4 hours after meals or in the middle of the night. It is relieved actually with food or antacids. Signs and symptoms of peptic ulcer disease include anorexia, nausea, vomiting, and bleeding. And these can occur with ulcers at either location. Bleeding may be mild or it could be severe. H&H should be monitored. Blood may be found in gastric content or in the feces depending on the location of the ulcer. Some of the major complications include bleeding, which is more severe, perforation or obstruction. H. pylori testing should be done on all folks that have peptic ulcer disease because, again, a lot of them do have H. pylori. Peptic ulcer disease can be diagnosed with upper GI series or with a EGD. Treatment for H. pylori will include antibiotics and proton pump inhibitors or an H2 antagonist for 10 to 14 days. Pepto-Bismol may be used for its antibacterial effects as well. Proton pump inhibitors stop the gastric acid secretions and then decrease erosion. The H2 antagonists, again, help with decreasing acid secretions. The Carafate forms this, viscid, sticky gel that sticks to the ulcer, and then it forms this protective barrier. And then antacids increase the pH and then also strengthen gastric mucosa barrier and also help with esophageal sphincter tone. Treatment includes a bland diet, again avoiding spicy foods, carbonated drinks, caffeine, and alcohol. Complications include bleeding, perforation, which can again lead to peritonitis, septicemia, hypovolemic shock from the bleeding, and then obstruction may be due to scar tissue and frequently occurs at the pylorus. Nursing diagnoses include acute pain related to gastric mucosal erosions, risk for injury, related to complications of the peptic ulcer activity, such as bleeding or perforation, and then deficient knowledge regarding the disease process and treatment. The care plan should provide teaching regarding complications of the medication regimen, completion of the medication regimen, even if symptoms are completely alleviated. So with stress ulcers here, the body's stress response can cause reduced blood flow to the stomach and the small intestines, which can cause ischemia and damage to the mucosa barrier, which then allows acid secretions to create these ulcers. Prevention is key. Some of the prevention strategies include quick trauma care, and this is to restore oxygen to the stomach, early feeding within 24 hours to help with the stomach returning to normal function. Insertion of an NG tube may happen, and this can be used for testing gastric pH and to help keep it above 5. Antacids or histamines or the carafate may also be given again to decrease gastric secretions, increase the pH, or create that protective barrier. So gastric bleeding, this can be from ulcers or perforations, tumors, gastric surgery, occult blood, or blood could be occult, which means it's hidden in the stool, or it can be observable, such as vomiting blood or those dark tarry stools. Symptoms will vary by severity of the problem. Treatment for hypovolemic shock will need to happen if present. Mild bleeding, they may have some weakness or just feeling a little lightheaded. They can also, as this progresses, have dizziness or diaphoresis. The patients are kept NPO just in case they need to go to surgery or need some type of endoscopic procedure to stop the bleeding. Medications such as Zantac are also given to help decrease secretions of the gastric acid. NG tube could be placed for assessing bleeding or to decompress the stomach. Certainly we need to really keep track of these folks and assess them for signs and symptoms of hypovolemic shock, which again would include hypotension, chills, thready pulse or palpitations or diaphoresis. The goal of treatment is to prevent hypovolemic shock and dehydration, so they may also get IV fluids or electrolytes as well. We also want to prevent electrolyte imbalances and prevent further bleeding. Nursing diagnosis for GI bleeding would be deficient fluid volume or risk for deficient fluid volume related to vomiting and blood loss. And again, the goal is to reverse or prevent hypovolemia. Gastric cancer, this is a malignant lesion in the stomach. It is the second most common cancer. Men are at greater risk than women. H. pylori infection is a risk factor. There is research being done to see if preventing H. pylori reduces the development of gastric cancer currently. Gastric cancer actually has a pretty poor prognosis, as metastasis is usually already present at the time of diagnosis. So it's pretty far along before diagnosis usually happens. Early on, there are really no signs and symptoms, and that's why diagnosis does not usually happen in the early stages. Late symptoms include indigestion, anorexia, pain that may be relieved by antacids. That's why when folks are taking antacids for prolonged periods of time, we want to make sure that they know that they should get checked out. They also may have weight loss, nausea, vomiting, or anemia. Signs and symptoms are often mistaken for those of peptic ulcer disease. You can see that there are some, they're very closely, the signs and symptoms are very similar. And then anemia can be from blood loss, which is common, and occult blood may be present in the stool. So again, that hidden blood that you wouldn't necessarily see, but that you could test with occult blood testing or those stool testing strips. Diagnosis of gastric cancer is made usually by an upper GI X-ray exam or a scope into the stomach or gastroscopy. They can also do some gastric fluid analysis to measure serum gastrin levels as well. There's really not any effective treatment for gastric cancer. The patient may have the tumor removed or a gastrectomy. Chemo and radiation may also be used, but again, they're not very effective. The patient will need TPN to provide nutrition if they do have a total gastrectomy done. There are gastrectomies that can be done, a subtotal or partial gastrectomy. The Billroth run is where the distal portion of the stomach is removed and the remainder of the stomach is attached to the duodenum. And then the Billroth 2, which is the other type of subtotal gastrectomy, involves the removal of a larger amount of the distal stomach, and then it's attached to the proximal end of the jejunum. With a total gastrectomy, this is removal of the entire stomach, and it's used to treat extensive gastric cancer. Here, the stomach is removed and the esophagus is attached directly to the jejunum. Nursing diagnosis include acute pain related to postoperative status, certainly fear related to body image changes, also because they're being treated for a life-threatening illness. So certainly those things can elicit fear and anxiety as well. Taking care after gastric surgery. Like most folks with any type of surgery, we're going to monitor vital signs very closely and respiratory status as well. We want to control pain. We're going to monitor intake and output, and then monitor the incisional site to make sure that there's not any excessive drainage or bleeding or signs and symptoms of infection. Most of them will have an NG tube, depending on the surgery, and if they do have an NG tube, then we have to do care for that tube as well. Just like with most folks that have surgery, we want to get them to ambulate early. And then we're going to monitor their abdominal status, pain, bowel sounds, those kind of things, and then provide education to them. So complications of gastric surgery can include bleeding or hemorrhage, gastric distension, and here we can put in an NG tube to help with decompression and also help with pain. Dumping syndrome can happen, and this is from rapid entry of food into the jejunum. They can have nutritional problems like pernicious anemia because now they have no intrinsic factor that is produced there in the stomach, or a reduced intrinsic factor depending on the surgery that they've had. Steatorrhea or fat in the stool. This is a result of rapid gastric emptying, which prevents the adequate mixing of fat with the pancreatic and biliary secretions. And then pyloric obstruction can happen as a result of the inflammation and scarring as well. So again, you can post questions in the discussion forum. We will also have discussion on these topics in class. You can always email me or text me or make an appointment